Today, Teresa López-Fernández from Madrid. So Teresa, you can feel free to start.
Thank you, Steve, for the introduction. Dear colleagues, thank you for attending this webinar. And first of all, I want to thank the ICOS Junior Group team for the opportunity to be part of this webinar. So we are going to present today, these are my disclosures, the first publication from the CARDIOTOX registry. And this project was born at IdiPAZ Hospital 10 years ago. And for those of you who don't know IdiPAZ is a university hospital located in the north area of Madrid in Spain. And the hospital was opened in 1964. Being at that moment the first modern hospital in Spain, and today it remains one of the largest centers in Madrid with more than 1,000 beds and serving a population of more than 800,000 people. And after the opening of the Autonomous University School of Medicine, IdiPAZ becomes its clinical reference, and in fact is strategically located in front of the university and 10-minute walks for two of the main cardiovascular research institutions in Spain, the CEMIC and the Instituto Carlos III. And additionally, we host a research institute, IdiPAZ, that includes 6 strategic areas and in which the cancer and the cardiovascular areas are the more active. And through these areas, it becomes the promotion of this CARDIOTOX registry. So the CARDIOTOX registry is a prospective, multidisciplinary and multi-center registry aiming at identifying the factors related with the risk of cancer-induced heart failure and assessing the utility of clinical, echo, and biochemical parameters for early detection of cardiovascular disease in patients treated with cancer therapy. 7 hospitals in Spain participate, including patients, according to a pre-established protocol that we are going to review. And each center should have at least 1 cardiologist and 1 oncologist actively involved in the recruitment and follow-up of patients. So these are the inclusion criteria. We include adult patients with new cancer diagnosis that receive cancer therapies with previously associated cardiotoxicity at least of 2%. These are the list of drugs that fulfill the inclusion criteria. And we also need an expected life survival of more than 6 months. So all study data are collected and managed using RedCap electronic data capture tool, hosted at IdiPAZ. And patients with previous history of cancer, chemotherapy, radiation therapy, or with known cardiovascular disease were not excluded. Patients were treated according to cancer and heart failure guidelines. And also there is a special care to monitor and control cardiovascular risk factor and cardiovascular diseases during the follow-up. So the recruitment starts in April 2012 and ends in October 2017. And this is the protocol of the study. Clinical data, blood samples, and echo parameters were prospectively collected according to this protocol at baseline, 21 days, 3 months, 6 months, 1 year, 1 year and a half, and 2 years follow-up after the initiation of cancer therapy. And the patient were followed in each center by the cardiologist and the oncologist who are responsible of cancer and cardiovascular therapy. And all data were centrally reviewed at IdiPAZ Hospital, and an event committee assigned the cardiotoxicity criteria. And also we have a central lab to process blood samples. So So the aim of this first publication from the CARDIOTOX registry was to define and grade cardiotoxicity based on current heart failure guidelines to determine the prevalence of common clinical, biochemical, and echo parameters currently accepted as indicative of cardiotoxicity, as well as the relationship with the current heart failure criteria and prognosis. So we include a total of 1,324 patients, but to improve the precision of cardiotox definition, we decided to exclude patients with pre-existing symptomatic heart failure or a baseline ejection fraction below 40%, and those in whom baseline data were not complete or who died because of non-cardiovascular reasons during the first 3 months. So at the end, we have a total of 865 patients that were considered for this analysis with a mean follow-up of 24 months. So the mean age of our population is around 55 years old. Most of our patients were female. These are the main demographic characteristics, as you can see there. 8.5% of patients have a previous history of cancer, most of them treated with chemo or radiotherapy. And there is also a high prevalence of conventional cardiovascular risk factor. And according to this risk factor, these are the treatment that were related with cardiovascular risk factor control and also heart failure prevention at baseline. So these data are not included in the article we are comment, but I think that are interested to comment just a few data that are now under review and that we have published, we have presented at the ESC last week. And we analyzed from the whole cohort of patients the relationship between cardiovascular risk factors and the risk of cardiotoxicity and the risk of mortality. And individual risk factors were not related specifically with worse prognosis, but when we label the cardiovascular risk using the SCORE scale, we found a close relationship between higher SCORE groups with severe cardiotoxicity and all cause of mortality. I'm going to describe for you all these type of severe, moderate, and mild cardiotoxicity in the next slides. So these are the baseline characteristics of our patient. We have a huge population of breast cancer patients with an important population also of non-Hodgkin lymphoma, and the rest of malignancies are less represented in the study. And most of the patients receive anthracyclines, 20% anti-HER2 therapy, 16% the combination of anthracycline and anti-HER2 therapy, and also 1/3 of patients receive less breast radiotherapy. So at baseline, we found myocardial dysfunction in a small percentage of our population. Remember that an ejection fraction below 40% was an exclusion criteria. In fact, the mean baseline ejection fraction was 64%, and also a mean baseline strain was within the normal limits. But at baseline, we found that around 20% of patients we detect an increase in baseline NT-proBNP or problems in GLS or a dilated left ventricle. So cardiotoxicity was defined as the presence of worsening myocardial damage during follow-up and was classified in 4 groups of non-cardiotoxicity, mild, moderate, or severe, according to the worst myocardial damage observed. And also we define a cardiotoxicity hard endpoint. This is a combined endpoint defined by all cause of death, cardiovascular death, and heart failure hospitalization is a general combined outcome accepted in the several heart failure morbidity and mortality trials. And with this figure, we try to summarize the classification of cardiotoxicity. We outline 4 mutually exclusive degrees of myocardial injury: normal in patient asymptomatic with normal left ventricular function and normal biomarkers; mild cardiotoxicity in asymptomatic patients with an ejection fraction over 15%, but with abnormal biomarkers or other abnormal echo parameters. That means diastolic dysfunction or an ejection fraction in the low normal level, or a significant decrease in the longitudinal deformation of the left ventricle. We label as moderate cardiotoxicity in asymptomatic patients with an ejection fraction between 40 and 50%. And severe cardiotoxicity was defined by symptomatic heart failure as per guidelines criteria, or an asymptomatic decrease in ejection fraction with an ejection fraction under 40%. And at the same time, we explore the prevalence of abnormal biomarkers and left ventricular dysfunction parameters using this recent classification published by the group of Alex Lyon. This is part of the Royal Brompton Cardio-Oncology Experience. And they propose this practical clinical strategy aimed to improve cancer treatment continuation in high-risk patients. And as you can see, it's different from our CARDIOTOX definition, because they describe 6 different risk categories: early biochemical, early functional, just with a decrease in DLS, early mixed, symptomatic HFpEF, asymptomatic left ventricular dysfunction, or symptomatic left ventricular dysfunction, but they do not consider the degree of ejection fraction below the normal limit. So here are the results of our CardioTox analysis. In general, patients with cardiotoxicity who develop cardiotoxicity are older and more likely have previous cancer therapies and cardiovascular risk factors. And in general, they have a lower baseline ejection fraction and ELS. However, baseline biomarkers, especially NT-proBNP, were not related with an excess in cardiotoxicity risk. We also find significant differences in the risk of cardiotoxicity regarding the type of cancer. And as you can see here, patients with non-Hodgkin lymphoma, leukemia, or colorectal cancer are more prone to develop severe cardiotoxicity, whereas breast cancer patients in general develop mild cardiotoxicity. So this table shows by the main
Teresa?
biomarkers. Hello?
Teresa? Hey, Teresa.
Hello? Hi.
This is Dan. Hey.
Hi.
Thank you
Dan,
so
how are
much.
you?
I'm great. How are you?
Fine.
Thank you so much for your presentation. So did you adopt the definitions of cardiotoxicity that Alex and his group have used, or do you use your own definitions?
For the article, yes, we use our definition and we compare the results in mortality and the percentage of patients who is in each category. We perform a comparison of both definitions, and the final conclusion are quite similar. I'm going to show them.
Sure. And then in terms of, so I understand most of these, or maybe the significant majority of these patients, were that no patient was included in the analysis that had pre-existing heart failure, correct?
Well, a few patients have mild pre-existing, no, heart failure, not. Mild cardiac diseases, because we have a low percentage of patients with myocardial infarction or atrial fibrillation. That previous symptomatic heart failure was an exclusion criteria,
right?
As well as an ejection fraction below 40%. Not for the registry, but for this analysis.
And so, why did you choose to do that? I'm just curious.
Well, because one of the main objectives of the publication was to try to define the prognosis of each cardiotoxicity category. So, if we include patients with heart failure at baseline, and we include patients with severe left ventricular dysfunction at baseline, it would be quite difficult to define or to separate the prognosis of a cancer-induced cardiotoxicity or severe cardiotoxicity.
Yeah, I know. So that's where it gets messy. But when you look at your data, you have a large percentage of patients are breast cancer, and for the most part, they're pretty healthy. They don't have a lot of other complicating factors. And then their outcomes are much better. When you compare that to lymphoma, for example, the rate of toxicity and all of that is much higher in those cancers, partly because they tend to be a little bit older, maybe not always, but they've also usually had prior treatment. So it's or their first therapy is very intensive. And so I think that most of our data out there is about breast cancer, which is good that we know a lot about breast cancer, but there's a lot of other cancers out there.
Yeah, sure. I completely agree with you. In fact, when we start to plan the statistical analysis of the study, we ask different statistical experts in the area, because our first plan was to try to use the whole population and just excluding patients with incomplete data. And incomplete data is a standard in registries, not in clinical trials. But they recommend us to avoid this bias in the definition of the prognosis of each cardiotox category.
Okay, thank you for clarifying that.
No, thank you for your question. Please, if you have more questions, go ahead and interrupt me.
Well, and also I just wanted to make sure that people were out there and that you didn't think you were just talking to your computer.
Thank you, then. Okay, so we were here, and this table summarizes changes in biomarkers and echo parameters during the follow-up. We need to analyze in depth some of these data, because this is not the objective of this first study. But as you can see in red, most of the significant changes in biomarkers and advanced echo parameters occur around 6 months, most of them earlier than 6 months, but we need to analyze in deep this data. And the only parameters that start to change before was NT-proBNP. And this is very interesting, because natriuretic peptides are considered extremely useful for heart failure diagnosis and prognosis, but there are not a lot of data in cancer patients, and in fact, we do not have a threshold value related with subsequent clinical ventricular dysfunction. But as I mentioned, we need to investigate in deep the meaning of all this data. So in this figure, we summarize the cumulative incidence of myocardial dysfunction parameters. And as you can see, a huge proportion of patients develop increase in cardiac troponin, high sensitive cardiac troponin T, or a significant decrease in the global longitudinal strain. However, the percentage of patients who develop left ventricular dysfunction with an ejection fraction under 40%, or with the standard definition from the Juan Carlos Plana document, a 10% decrease in ejection fraction with an ejection fraction below 53%. We found only a minor percentage of patients that that are allocated to this definition. And this table details the prevalence and different grades of myocardial impairment through the study. And in the worst situation, only 16 patients do not develop any clinical echo or analytical abnormality, and most of the patients develop at least mild cardiotoxicity, with a low percentage of patients who develop moderate or severe cardiotoxicity. And these are the Sankey diagrams showing the number of patients in each category at baseline and during follow-up, and we compare our classification with the Royal Brompton classification. And so we categorize our patient in our classification, and we categorize also our patient according to the Brompton classification. And as you can see, most of the patients with no myocardial injury at baseline or mild myocardial injury at baseline remain in the same mild cardiotoxicity category at the end of the follow-up. And the result of this graph is quite similar, because this orange line refers to patients with an increase in cardiac troponin and increase in GLS, the most common finding in our study, and most of them remain in the same category at the end of the study. So summarizing this data, 62% of patients did not suffer any impairment during follow-up. 31% developed mild cardiotoxicity, and 2.8% moderate cardiotoxicity, and 3.1% severe cardiotoxicity. Probably the relatively low prevalence of moderate and severe cardiotoxicity can be related with the fact that we include a lot of breast cancer patients, as you commented before, Dan, and probably other cancer patients have a higher cardiovascular risk or a higher prevalence of previous cardiotoxic treatment. But probably this could be also partly explained by the exclusion of patients with severe cardiovascular disease at baseline, and also by the fact that all the patients were followed in a cardio-oncology department or team. So when we detect minor forms of cardiotoxicity, we start in most of the patients some kind of cardioprotective drug, or we increase the monitoring, or we try to improve more the control of cardiovascular risk factors. And
so, you know, so Teresa, you bring up a very important question. So from the point of view of, if you just look at the degree of myocardial dysfunction, you know, it's pretty low in terms of anything significant. The mild LV dysfunction, of course, you don't want any LV dysfunction to develop. I mean, so the mild category is still quite important. But as a way of documenting that we're enhancing practice, can you tell, or do you have any data about how often you did start some sort of cardioprotective therapy, whether it be an ACE inhibitor or a statin or aspirin or whatever you did? Is there any way that you can show the impact of heightened surveillance and more proactive treatment?
Yes, we need to work a little more in this analysis, because the nature of the registry do not give us much power to establish the role of cardioprotective treatment, because it was one of the objectives pre-specified of the registry. And we are analyzing in deep this data, but during treatment, during the follow-up, as you can see, the percentage of patients who were on beta blockers, aldosterone antagonists, ACE inhibitors, ivabradine, or statins increased significantly through the follow-up. But in fact, we need to separately analyze this data. But I think that we are not going to have enough power to really detect the impact of this cardioprotective therapy. But from the clinical point of view, is it clear we do not leave their patients at their own when we detect problems at the echo parameters, even minor problems at echo parameters. The patient is monitored as in our daily practice, so we decide when to start cardioprotective treatment. Of course, each cardiologist in different institutions has their own criteria, but in general, because we are only 7 institutions with and we work all together, building the preliminary cardio-oncology group in Spain, protocols were quite similar, and the decision on when to start cardioprotective treatment were quite homogeneous from the practical point of view.
Oh, it's Joe. The same light went on in my head as in Dan's. But I think even more simply that because it's always a big question to prove that we really make a difference. Can you separate what happened? Forget cardioprotective drugs, which are harder to sort out, but just people who saw cardio-oncology versus didn't. There was a difference in outcomes from the standpoint of treatment completion and development of more significant heart failure. That may be easier to do.
Okay, yes, that's a great idea, for sure. We are still working on the database, so I think that this is one of the main objective that we need to have in mind. Yeah.
Yeah, I think the challenge there is that, so you obviously built this very, excellent network, and the reason you built it, or the end product of that development of that network, is that you've had, besides yourself, of course, the multiple institutions that you're working with are interested in this topic enough to do a registry, so they're engaged in the patient's care. So it's going to be really difficult to find out the outcomes of people that are not in the registry, who are not engaged in care, and that's where you would see a big difference. And so I don't know if there's any way to find some comparator group that didn't sign up for the registry, that may have been seen at these different institutions. That may be a comparator group for those that saw a cardio-oncologist versus those that didn't.
Yeah, this is also a great idea. Yes, we can try to find a huge number of cancer patients who are not included in this registry because they were part of other clinical trials or different studies. It could be a great idea. In fact, we also are awaiting the result of the Cartier study. The Cartier study is an Spanish registry that try to answer this question: how important is cardio-oncology follow-up, and is focused on hematologic patients. And the patients were divided in standard follow-up, just with the hematology surveillance and, of course, biomarkers or cardiac echoes according to local protocols, versus to refer this patient to a cardio-oncology clinic. And he's still recruiting patients, but in the preliminary analysis, they show us it seems that we are going to have very interesting conclusions.
Yeah, I think the big issue, of course, is, you know, on one level, you want to justify your existence. So, you know, you want to say that whatever it is that I'm doing in the world is productive. So we all want to believe that. And so then the question is how do you document that? And if you were trying to be the most academic, you would say, okay, I take 100 patients, 50 of them are followed by a cardio-oncologist, you know, by whatever tools that they feel are necessary, and 50 are not. Well, you'd have to, in order to really prove your benefit, you know, you'd have to randomize those patients. And I can tell you personally that if you went to of 100 patients, 50 of them, you said, okay, we're not going to follow you. You're not going to have a cardiologist interested in your cardiac care following you. You're just going to be thrown out to the wolves in the wilderness. And you know, do you think a patient would agree with that?
Don't think so.
I mean,
currently
no.
don't think so.
I mean,
Probably in 2012, when we started the cardiotox study, some of them, in fact, some of them reject to sign for the registry. But now it seems quite difficult to do that. Yes.
No, I just think that so you have to come up with ways in which you can show the benefit of your involvement.
We have recent examples during the COVID pandemic, because in fact we are seeing this. Exactly last week, I was on the clinic, and some patients who start cancer treatment during the pandemic, and theoretically they have low cardiotoxicity risk, and some of them, they experience problems because the first baseline evaluation or the first month monitoring was not done as per our standard protocol due to some limitations. So in fact, it's difficult to demonstrate, but we all know that cardio-oncology impact in daily practice.
Well, and then the other part, of course, you know, I don't think we could have a conversation about cardiotoxicity without me throwing in something about biomarkers. So, you know, in this case, do biomarkers aid in your evaluation in any way? Did you find that in your registry?
We found consistent data using high sensitive cardiac troponin, but very confusing data based on NT-proBNP, because I don't know why, but some patients develop a sudden early peak in NT-proBNP during the first 1 or 2 months, but this is not related with left ventricular dysfunction or cardiac troponin, and we are trying to understand why, because of course NT-proBNP is a very sensitive parameter, but we also have a huge experience using NT-proBNP in many heart failure scenarios, and is a critical parameters in other areas. But the data that we have collected from NT-proBNP were not very robust to confirm its value as a diagnosis tool or prognosis tool or prognostic tool in these patients.
Yeah, I mean, we could debate that point, but the the main point that I would say is that if you check a biomarker, whether it be troponin or NT-proBNP or whichever biomarker you're referring to, but certainly those two are the ones that we're used to clinically in all sorts of cardiology contexts. But the point is that if your troponin is elevated or your NT-proBNP is elevated, it doesn't tell you to do one thing or to do two things. It tells you that this person is at higher risk. It's not telling you what to do. It's telling you that this is no longer a stable patient. And that, to me, if we use the biomarker as an indicator of risk, high risk or low risk, that's its real value. It doesn't really matter, if you're trying to correlate a certain degree of rise of troponin or a certain degree of rise of NT-proBNP with subsequent LV dysfunction or some other parameter. I don't think that's possible. We haven't been able to do that at all in any heart failure trial that I'm aware of. Even when you're following those things very carefully. But if you categorize patients into low risk or high risk based on those biomarkers, then I think that is the real value in those tools. It doesn't tell you what to do, it just tells you pay more attention.
Yeah, completely agree. You want we continue with the result of the CARDIOTOX? Just I have 4 or 5 slides more.
Yeah, I wasn't trying to sidetrack you.
No, I'm happy to continue to speak with you and not to continue with the presentation. It's okay,
No,
but well, anyway.
Please
So,
continue. I'll try not to interrupt.
These are the mortality data for our cohort. Globally, 6% of patients died during the follow-up. And in these curves, A was we divide our patient according to our CARDIOTOX classification. And on the right, you have the mortality curves of patient according to the Royal Brompton classification. And all cause of mortality was higher in patients who developed severe cardiotoxicity. Our severe cardiotoxicity was patient with symptomatic heart failure on an ejection fraction under 40%, and severe cardiotoxicity at the Royal Brompton classification was symptomatic heart failure or low normal or an ejection fraction below the normal level, but they didn't differentiate the level of left ventricular dysfunction. So in any case, data are quite similar, and it seems that a patient who develop severe cardiotoxicity experience a much higher mortality with a hazard ratio of 10. So I think that this is a very important message because we need to improve our knowledge about how to avoid that patient with mild or moderate cardiotoxicity progress to severe cardiotoxicity. So is that you say before, Dan, that all level of cardiotoxicity are critical in cancer patient, and we not need just to focus on severe cardiotoxicity. Of course, if a patient develops severe cardiotoxicity, this is well related with all-cause mortality because some of these patients need to interrupt cancer therapies. So this is another important goal to avoid in our daily practice. And what we need is to increase our work and our knowledge on how to prevent this mild to moderate cardiotoxicity stage progress to severe cardiotoxicity. Of course, the registry has. Go ahead.
Yeah, this is me, York. Hello, everyone. This is where we can have a universal definition, it looks like.
Yeah.
Cardiotoxicity, just to throw that in. But it's impressive how these data overlap. Congratulations, Teresa.
Thank you, York. And well, with this registry, we have several limitations, and we start to design this registry in 2011. We start to recruit patients in 2012. In the last 8 years, there are huge advances in cardio-oncology, and probably if we wanted to redesign the registry today, some of the way to collect the data will be completely different. For example, we do not specifically gather data regarding anti-diabetic medication, and now we have recent data on how some anti-diabetic drug may prevent heart failure. But okay, we have this main limitation. Patients with abnormal biomarkers or echo values at baseline were included, but we exclude severe cardiomyopathies. There were no central echo lab, and this could be a main limitation. In fact, we try to work with hospital with similar echo protocols, similar echo softwares to analyze 3D and strain. And yes, one hospital do not have the same software, but as you know, recent imaging publications do not show significant differences in GLS when we compare Philips and GE strain. And of course, we miss some data. We have some incomplete data in some visits, and this reduces the target population for these studies, and maybe also reduces the percentage of different degrees of cardiotoxicity we have in our studies. So as take-home messages, we think that to define cardiotoxicity as new worsening myocardial damage after initiation of chemotherapy is an easier way to define cardiotoxicity. And it's also very important to grade the cardiotoxicity because as in different heart failure scenarios, the risk or the prognosis is completely different. And of course, there is a high incidence of ventricular dysfunction during high-risk chemo. Severe cardiotoxicity is related, oh, sorry, this is a mistake. We had 10 fold increase in total mortality. And there is, of course, much work to do. We need to finalize the analysis of imaging data, more than 5,000 echo. We are also analyzing some genetic data for these patients. The fact to try to understand how cardioprotective treatment help or not this patient is also critical, as well as validation this cardiotoxicity gradient in our series. And just before to continue with the discussion and to answer your question, I want you all to remember that we have in the next weeks, October 1st, the virtual Cardio Oncology Summit, and I invite all of you to attend this Cardio Oncology event. So if you have questions, comments, please go ahead.
Fantastic. So Teresa, are you still enrolling?
No, we decided to stop the enrollment during 1 year in order to be able to complete the long-term follow-up, because in fact our first patients now we are working on scheduling those who are alive, of course, for a 5 or 8 years follow-up, in order to be able to have more data, and with this more data to probably to design or to redesign the database and to complete it with more data.
Okay, so it's a perfect opportunity to match your data set and the SURVIVE registry into one.
Mm-hmm.
And then you could start to enroll again.
Mm-hmm.
So I know we talked about that many years ago and never quite happened, but since you're using REDCap, and that's what we're using, and we have the same basic intent with both registries, seems like somehow we got to figure that one out.
Mm-hmm. Sure, we need to do it definitely.
Hello, everybody. Teresa, it is Sergey from Ukraine. Thank you very much for excellent presentation. I have a question regarding, in general, about 40% with heart failure or LV dysfunction and low rate of using cardioprotective therapy, especially beta blockers. And of course, we can improve survival of our patient in two ways: for prophylaxis cardiotoxicity and for treatment LV dysfunction or heart failure. How we can change this situation, because if we manage patient and perform follow-up and low rate of cardioprotective therapy below 10% of cardiotoxicity, what do you think about these questions?
So not sure I understand what you mean, but of course, to try to optimize heart failure and left ventricular dysfunction treatment is critical in all these patients. Sometimes not all patients receive the best cardiac medication, and we have several series. Recently, a series from the Mayo Clinic in 2016 show how many patients with cardiovascular diseases are not able to follow the best cardiovascular therapy during cancer treatment for many problems, not only because they are not under cardio-oncology surveillance, but due to drug-drug interaction, or because they are before cancer treatment using ACE inhibitors, and during the treatment blood pressure decrease, or they have a septic shock, or they have several problems that leads to the discontinuation of cardiac treatment. But it's quite complex to manage as in daily practice cardio-oncology, but not sure I answered your question, because not sure I understand you very well.
I asked about low rate of prescribing beta blocker. It's less than statins, and
in
I
our
think
registry, in the CARDIOTOX registry.
Yes.
I do not have an explanation for that. I think that you refer to this low percentage of patients under beta blocker therapy. In fact, I think that most of ACE inhibitors were prescribed because of hypertension, and ACE inhibitors and ARB in our area are the preferred option for blood pressure. And beta blockers are added to ACE inhibitors or ARB in patients with poor blood pressure control, or in patients with atrial fibrillation risk. But this is not the percentage of beta blockers in patients with heart failure. This is the overall percentage of beta blockers treatment during follow-up in all patients categories. So I have not the exact data of the percentage of heart failure therapy in patients with severe or moderate cardiotoxicity, but for sure is much higher. I think that I probably have some of this data here. That's no, sorry, I can't send you the data, because globally I have the percentage of beta blockers in each cancer category, in each CARDIOTOX category.
It will be interesting to analyze cardioprotective strategy in patient with cardiotoxicity who's royal or who not royal, or patient on beta blocker, ACE inhibitor, or without with cardiotoxicity, and to see how big difference between these groups.
Yeah,
Yes,
I think that, there have been a couple of, different trials that have looked at the, either renin-angiotensin system inhibitors and or beta blockers for cardioprotection. That whole concept is pretty complex, but I would think that in a more global way, just showing your involvement, whether it be ACE inhibitor or a beta blocker or a statin or whatever, whichever form of cardioprotection you initiated, I think would probably be a better parameter than not doing that, because I think that each of those drugs has its potential benefit. If you show that, in some discipline study that there's only a very minor benefit of one specific drug, I don't think that really answers the question. I think that the issue is whether cardio-oncology involvement and optimal medical therapy in whatever form that is would be a more robust measure of your involvement. So I think that it's one thing to focus on one particular drug and say that that's helpful, but it may not be helpful in all situations. But the combination of all the therapies that you would do to be helpful or cardioprotective in these patients would be a much more robust measure.
yes, I completely agree. In fact, nowadays we use a lot sacubitril valsartan in patients with cardiotoxicity, and these data are not in the registry.
Teresa, may I ask a question? Ron Krohn.
Yes, please.
When you have the aldosterone inhibitors, do you distinguish between eplerenone and spironolactone, especially in the breast cancer patients where, as you know, spironolactone will be an androgen blocker and potentiate estrogens, where of course eplerenone doesn't? And I just wonder if there's I'm just kind of curious what the usage is of spironolactone in breast cancer patients. As far as I know, there's no study on the subject, but it seems logical that spironolactone would be a bad drug to use, especially if you have an estrogen sensitive breast cancer.
Yes, this is a very interesting question. In fact, there is a small study on eplerenone protection in breast cancer patients. Unfortunately, in the registry, we do not distinguish eplerenone and other aldosterone antagonists. No, we do not have this data, but for sure, it's an interesting topic also.
Well, thank you.
Thank you.
Excuse me, may I have a question?
Yes.
Thanks for great talking. I want to ask you a question. Suppose that some patient come to you with, for example, ejection fraction less than 40%, or less than 35%. And oncologist consult with you that I want to start chemotherapy. What is your plan? Do you agree? Do you allow the oncologist to start chemotherapy, or with drug, without drug, or stop any cardiotoxicity? What is your plan?
Well, this is a very interesting. Yeah, this is a very interesting question and quite complex to answer, because we need to individualize each case. But for example, from the Royal Brompton article that I comment on, they receive a lot of patients in their clinic with left ventricular dysfunction, and with a comprehensive cardiovascular assessment and monitoring, and using the best heart failure treatment that you are able to give to the patients. Most of them are able to receive cancer treatment. Of course, when I receive one patient with this characteristic, we need first to, if there is a new diagnosis of left ventricular dysfunction or heart failure, to try to rule out some reversible causes of reversible situation like ischemic heart disease or myocarditis or other things. We need to optimize heart failure treatment, and we need to try to use the less cardiotoxic treatment from the oncological point of view that may work with the oncologic pathology. But in our vision is better that the patient receive a treatment if this treatment has the option to cure or to maintain in a good situation the patient, that the patient dies in a few months, because you are not going to be able to give them a cancer treatment that could be effective. The situation is completely different in breast cancer or in pancreatic cancer, of course. So it's necessary to individualize the oncology prognosis and the cardiology prognosis. But if the oncology prognosis is quite reasonable, I think that we need to try that patient receive a cancer treatment. And if we need to review we need to review very close the patient in our clinic.
Thank you. I mean that, for example, we have some patients that they have, for example, prognosis survival for more than 1 year, and he or she come to you and have a ejection fraction less than 40%. Is it enough to just prescribe heart failure medication and searching for the secondary reason? Is it enough or not? Or it should be the ejection fraction should be increased more than 40%. Do you any plan for this or not, individuals and by your scientific experience?
In our daily practice, these patients were treated for their cancers. At least they have severe symptomatic heart failure, and in this case, the patient was admitted at hospital. The heart failure was stabilized, and we tried to find the less cardiotoxic regimen to treat the patient.
Yes, thank you so much.
Right. I have another question. Do you have any? Are you following desroxazine or Zenocard in patients? You didn't see many. I didn't see many sarcoma patients in the registry, so it's probably unlikely that there was a lot of doxorubicin given. But I just wondered if you did monitor desroxazine in this database, and if you did, what kind of results did you get?
Yeah, I'm sorry, but dexamethasone is not used in our institution as a preventive tool from the oncologic point of view. I'm not sure. I'm not able to say you what are the main reason, but it's not available in our institution and in the other institution that participates at the registry. We have around 20% of patients treated with anthracyclines were treated with liposomal anthracyclines because of cardiovascular risk factor or because of other high-risk criteria, that we do not have patients treated with dexamethasone.
Thank you very much. This is a wonderful talk, by the way. Thank you.
Welcome.
Well, Teresa, thank you so much, and we are really very proud of you for being able to do this registry. So I think it's really fantastic, and we loved hearing about it. We have to figure out a way to put our registries together and start enrolling again. And I think that it's this kind of data that I think really helps us understand how to improve practice. So that's what we're doing this for.
Sure. Thank you, Dan.
Okay. Well, thank you, everybody. And Steve, who do we have next week?
Next week, Maria Sol Andres with Alex Lyon will be presenting on cardiotoxicity in low-risk patients, the cases that surprise us. So I think that would be very good.
Sounds good. Teresa, thank you so much. And we look forward to the virtual meeting in October that you are hosting. And thank you so much for all your efforts, especially in that regard.
Okay, have a nice day all.
All right, you too.
Thank you very
so
much.
much.
Thank you,
Thank
Thanks
Teresa.
so much.
Thank you.
Bye,
Everybody.
thank you.
Teresa,
Hello.
you
Yes,
have
I'm
time
still
for
here.
Yeah, I wonder, Albuena from Oslo, are you there? She had a question that didn't get answered.
Sorry.
Yeah, maybe her microphone's not working. Albuena, are you there?
She is asking a question in a chat or in.
Yeah, it was in the chat. Yeah.
How can I see the chat?
Let me read it to
Sorry.
you. If she's still on, she can maybe hear us. She wrote, you showed that the prevalence of severe cardiotoxicity was low in this analysis. This might be due to the exclusion of patients with established heart failure. Would there be a point to include these patients since they have a higher risk of developing cardiotoxicity?
But how can we answer her? Do you have her mail or?
Yeah, I can email. I think she's still on, but maybe her microphone
She's
wasn't
listening
working.
to us? Yes,
I
she's
think
listening
so.
to us?
I think so.
Okay. So yes, for sure. The fact that we exclude a patient with severe left ventricular dysfunction minimize the percentage of severe cardiotoxicity, but probably the most important, because the percentage of patients with severe left ventricular dysfunction was not high at the end at baseline, even if we exclude this patient, but probably what helped us more to minimize the risk of severe cardiotoxicity was the cardio-oncology environment where patients are treated. And this is difficult to confirm or to justify statistically. We are trying to working on this, but probably is the main explanation.
All right, thanks for taking the time. I'll if that didn't work, I'll connect the two of you by email, if that's okay.
Okay, that's fantastic. Thank you, Steve.
Okay, thank you so much, Teresa.
Have a nice day.
Yeah, you too. Bye-bye.
Bye.